we start with the first keynote by none other than Madam Radhika Tandon, who is the Chief of RPC, All India Institute of Medical Science. Madam is a great surgeon, great academician, great clinician, and we are so blessed to have her with us today in this ARC program. So, Madam, over to you, please, for the first keynote.
Thank you so much for giving me the opportunity to speak at this really wonderful session. Can I have my slides, please? So it's really encouraging to see the buzz around teaching and education. Earlier, in most conferences, the maximum attention was mainly to surgery and research to some extent. But now, with over time, teaching and education is also getting the deserved.
Change slide for Dr. Radhika Tandon.
So I'm going to be talking about the summit story. Yeah. Are you giving it on this podium? Yeah.
It's coming.
So here is our summit story. It's not coming on this. Should I go that side? Okay.
Sure, ma'am.
Okay, a little window into how things are at RP Center, how an institution gets the best out of residents year after year. So the importance is when you have to get something out of residents, you have to give it a priority and you have to maximize their potential. We have to realize that everybody is not going to be the same. So you have to customize and tailor-made your approach. And of course, there has to be an institutional commitment to excellence. And the RP Center, being part of the All India Institute of Medical Sciences, which was established in 1956, epitomizes that. Now, the core pillars of resident success. Now, when we want a resident to come out of the halos of our institute, we want that person to be a complete ophthalmologist, which is not only in terms of the professional skills, but also a complete human being in terms of being a human resource for teaching and also having a very empathetic attitude towards patient. So for this, there is, of course, a strong mentorship, faculty guidance, a structured and dynamic curriculum, continuous assessment and feedback, a supportive learning environment, and the effective mentorship and guidance where the faculty play a role model. And along with the faculty, we have a whole cadre of other people engaged in this teaching activity, directly or indirectly. They could even be an OT nurse. It could even be a technician who is using a piece of equipment. And one-on-one coaching, career guidance, and encouraging independent clinical decision making. That's the other thing. In the course of their day, there has to be some point of time where the person is on that point where he or she has to take the decision that this is what I'm going to do, and they should have that freedom and flexibility that if in doubt, I can go and to the next person, and I will get the guidance required. And curriculum design and adaptability, we have to balance theory with hands-on practice, and it will also depend upon each institution what is the patient care abilities or the patient care freedom available. There could be a private institute, it could be a public institute, there could be large number of patients, few number of patients, so you have to customize according to whatever is available as your resource. Incorporating latest research and technologies, customizing it, and then a continuous assessment and feedback, which would be both ways. And generally, you would like to have a supportive learning culture. This is something that came naturally to us because it's always been a tradition right from the inception. And not to forget a good work-life balance and a mental health support, which is becoming very, very important in recent times. Teamwork and collaborative learning, not only vertically, but also horizontally amongst the peers, building a culture of innovation and research, and then case studies of successful interventions. This can make a lot of difference to use best practices, and this kind of forum that I've seen in this session and the previous session is a wonderful example of learning from each other. Innovating teaching methodologies and lessons learned both from people senior to you and also from the past. There are, of course, challenges and situations. There are new age barriers in residency experience. There have to be strategies to overcome burnout and stress, not only among residents, but also among faculty. After some time, you become a bit jaded, perhaps, because you're overloaded with work and you're doing the same thing day in and day out. So you have to rejuvenate yourself and enhance engagement and motivation. And the future of residency training, there will be changes with AI applications and adapting to evolving healthcare needs. So I'll give you a few examples. It's not possible to capsule in a small time everything that we have learned over the years, but I would like to share a few examples from our center. This is just a snapshot of the annual report I presented at our 58th Foundation Day celebration on the 10th of March. And this time we thought I'd keep the theme as legacy. Why was it legacy? Because one needs to, as I said, remember what we have learned from the past. We've had several chiefs of the center, and each chief has added in some way. And now I have a position, I'm in a position of leadership myself, and I would like to, carry the tradition forward, and at the same time add a little bit of my own to this journey. Just a little word about our founder chief, Dr. L.P. Agarwal. So this is what he had been given in his, when he was in England, he had been given this little bit of written thing in his recommendation of all the Indian postgraduates who have been at the Moorfield since the war. So you can understand with a very challenging time in England as well, where they had to build their own country and their own training. There has been no keener man and no man who has done better in his examinations or work harder to gain experience in every branch of the subject. I showed this because I wanted to reinforce to everybody, including the faculty, that one should know more and more about less and less. As we all do, we may be cornea specialists, retina specialists, diabetic retinopathy specialists, and so on. But we must not forget that we must also maintain our knowledge across the board in other subjects as well. That was the only purpose. And if you see, as an institution, there's a huge number of students, huge number of faculty, and a whole team of people working. But not to forget, as I said, the nursing staff and the administrative staff. So we need everybody to engage into making the whole learning experience to facilitate the residency program. We lost our chief, Professor Supriyo Ghosh, last year, and Dr. Supriyo Ghosh had a very one-to-one interaction with residents, and he had a little different lifestyle. So he used to work throughout the night and have a different work culture and a different timetable. But then he could say that RP Center is truly working 24 hours, because there were some faculty who would be working in the day and Dr. Ghosh would be working throughout the night. And then we had Professor Tityal, who superannuated last year. And here again, we had a person who did a lot to improve the sort of the surgical training, and also did a lot for the residents in making new programs. So we had our anesthetists also. So this is one of the things, these are the opportunities where we think back of a person who has given dedicated a lifetime to the institute, and we have young people who are attending, and there's the threshold of their career for them. 30, 40 years seems too far ahead, but it's just a thing to motivate and to encourage them. So this is how we try to engage everybody in realizing that there should be no compromise in quality. Now, looking at patient care again, as I said, the challenge that we face now is patient care has expanded so much. Residents are very much a part of that patient care. So there'll be junior residents and senior residents. Senior residents are more for the service delivery, but they have to teach alongside. And there are junior residents who have to learn as well as deliver the patient care. And patient care has expanded to such a huge extent because the number of procedures has increased. We have daycare surgeries, which has increased, and the amount of intervention that we are offering to patients has increased. For example, intravitreal injections. And so with all of this, one has to keep the balance. One has to reorganize your workflow, reorganize sharing of responsibilities, not put everything on the doctors, start using the other staff to take care of some of the responsibilities and share the burden. We have investigative laboratories, for example, where high-end machines and equipment, you may not always be able to allow all the residents to handle one-on-one, but they are encouraged that if you have any patient who requires any investigations, try to take some time off and accompany them to see what the other person is doing. So as an apex institution of ophthalmology, we do have a lot of responsibilities. We support the other AIMS and RIOs, but we try to take with us the residency feedback from the other institutes, and also we have a lot of our students who are now the faculty in the other institutes. So we have this ecosystem of sharing and trying to bring, come back to the institute and say we cannot rest on our laurels. We have to remain on top, because everything we do is in the lens of everybody else, and you're in the public eye. So for education and training, one of the key contributions of Dr. Tityal has been to help develop our surgical skill lab. So that has really been of a very nice international standard. So we have wet lab training, and we have an inbuilt system where they have to go through that structured system, then they get certified to do their ECC, and then certified for phacoemulsification, and then they're allowed to operate on the patients. And again, it is with assistance and so on. Then we have new innovative methods of quizzing and trying to get the residents involved in various activities throughout the year. Just to give an example of our training alumni from the defense services. So this is just a small snapshot. Similarly, we've had alumni training from various other institutes, RIOs and so on. And we also do get a lot of requests for cataract surgical training through the National Program for Blindness Control and Visual Impairment, and there we have to draw a line, because we say unfortunately we can't support it because we have so many residents of our own, and we cannot compromise on that. So sometimes we have to know when to say that no, we cannot stretch further beyond this point. I feel that optometry training is something which requires a certain amount of thought. There is a concept that optometrists are a competition or a challenge to ophthalmologists, but I don't agree with that view. I feel they're a very good paramedical support staff, and as we're going ahead, there should be more collaboration and making sure that they can share a lot of the responsibilities in high volume, high burden settings, and we have tried to rejuvenate our optometry training program. Nothing can be done without research, and here all MD students do a research thesis topic, and we encourage them to publish, and we have a good number of our faculty who have made it to the Stanford list of top 2% highest cited researchers. So capacity building, we like to go further and further. We're recognized as the World Health Organization as Prevention of Blindness Institute. And then there are the outreach activities, which is again a way of residents realizing and letting them stay grounded. We don't want them to only think that ophthalmology is high income, high impact only in big cities, but there is a lot of work that has to be done in the periphery, not to forget the work on eye donation and transplantation. And then we have an annual Foundation Day celebration where we give them the opportunity to have an experience of what we have today. So we would like them to be involved as speakers, moderators, and organizers. We have the various recognition of international and our own national faculty and alumni who have reached great heights, so that they know that this is something that they can aspire to. This year we had an overwhelming number of people who wanted to speak and participate. So we did the first silent conference where we could have two halls in the same sort of halls working together. And then the Teachers of Tomorrow session is another very, very successful model where we have the residents come forward, and then they give little capsulated teaching, and then they are given awards at the end of that. So in all, I would say that how do we keep them engaged day after day? It's certainly requiring a lot of hand-holding, being alert as to what's happening, and a teamwork of a whole lot of committed people who are in academia for a reason. I'd like to share that we'll be organizing the Comprehensive Cataract Conference for the International Society of Manual Small Incision Cataract Surgeons this year in November, 7th to 9th. So I hope people would register and participate. Thank you.
Thank you, ma'am, for this very informative lecture, and we have all learned so much, like what amazing teaching and training program going on in the Apex Center. So any question for madam from any one of you? Would you like to know anything further? Okay. There's a slight change, Dr. Meenakshi, if you don't mind, because Dr. Deepak needs to go for judging a session. So after Dr. Deepak, we'll follow the normal sequence, I mean, whatever it's mentioned here. So over to you, Dr. Deepak. So Dr. Deepak, madam's certificate. Madam, your certificate. Asked him? Oh,
Waiting for the certificate. Can I ask you one question? How do you ensure that the faculty don't have a burnout?
Yeah, faculty are also, prone to burnout, and it's just that faculty also are prone to burnout. It's just to be mindful of it, and then being there to let them, give them some time to take off also if necessary. So they need a little bit of free time if possible. Sometimes they have challenges at home. So you can be a little flexible for that particular, phase that they're going through. But obviously it cannot be forever. So you have to have a one-to-one, and sometimes don't talk to them in front of everybody. Take them aside, talk to them separately, and often you are able to get them back on track.
So Dr. Deepak Mishra is a member ARC of the Central Zone, and he is a professor from Banaras Hindu University. He is also an amazing teacher and a great clinician and also academician. So over to you, Dr. Deepak.
Thank you, ma'am. Thank you, Meenakshi ma'am, for including me in his mega project. My slides, please. So, we all know that there are many ways of the teaching, either surgical, online, or different thing. But the wet lab teaching, which is the main teaching as per my vision is concerned, in a different setup. So I'm not going to tell or project something on what are the advantages or what are the things. But as Meenakshi ma'am told me, you have to say something or give idea how we can set up a wet lab, either in our hostel or small clinics or a small DNB institutions like that. There is no financial interest, although I will say or suggest the names of the few companies or few things which from where we can take the help and other thing as a low cost. So why wet lab is important? We are not going in that because other authors will concern. But yes, one thing is important, that the wet lab is the building block for any surgical training. And the best thing is whatever we can do, it is a risk free. And there will be no mental tension to any of the residents or the other one. So basically I divided my talk into the three parts. Means first is the wet lab setting. What is the space required? Most of the time when I will go for the DNB or NMC inspection, institutions are asking, sir, it required space. What is the ideal space or where we can start it? What are the requirements? Is any curriculum available or based on which what we can go? Means just not only the setting of wet lab, at least there should be something which guide us that yes, we can follow this curriculum. And finally, each and every point, the cost management is the important thing for the setting of wet lab. So space, what I can say that ideally the space for setting of any wet lab should be in the main hospital building. Means most of the time resident can go wet lab after doing their clinical works or OT, whatever they are. So if it is in the main building where they have a EGSS, can go anytime, just like adjacent to emergency or the ward side, then it will be good that they can practice after their work. And the space should be good enough at least to provide space for the two. One is the trainer and the training. And what I've gathered from more than 1 decade of the SSTC training in AIOS and 75 other conferences is that an ideal room size will be 10 by 10 feet. Means what we can get it as a standard room size. This is the layout. Means if we have a room of 10 by 10 feet, it will be good for a setting of wet labs for whatever the courses we have for the common one. And these wet labs will have some requirements like you have seen here. At least one microscope will be there, revolving stool, and if there be a side wing system in the microscope, it will be good. If not, then at least one TV or another thing will be attached with there so that anyone can go that. If anyone wish to ask or go for the larger training, means that faculty is going to tell them or guide them as initial for a batch of 5 or 6, then this 10 by 10 feet room is good enough that one can perform, and 3-4 residents can sit or the persons can sit, and you can explain at a once, means not explaining them all 4 or 5 different times. You will take time. So once you explain them, one resident can perform and another can watch it with that. For the bigger setups, like ma'am is there, Arvind is there, lot of people are having, they can go for the bigger area or the bigger workstations, but there will be some distance. Mean this the wet lab planned for an open space like this one of the space, then you can have a distance of at least 1 feet in between the two stations, so that one cannot hear each other's voice and not disturb. Now coming to the second part, consumables. Again, it depends upon the what are the nature and type of surgery we are planning to teach, and how many persons are the trainers you have. So all these are the common requirements which you can have anywhere. Either what we have done from our residency is the discarded sutures are prevented, but now RO Lab is providing us that is a low cost sutures with the wet lab sutures. Mean these are the non-sterile sutures, and always supporting us in AIOS and other places. They are giving us lot of things. Now APPA company is also giving unsterilized visco and other thing at the low cost, so that we can get it from there, either RO Lab or the APPA, and we even directly purchase from there. These are all the materials where we can do and practice. We already did, but these two things is just slightly different one. Means nowadays phaco training can easily be done on these wax eyes. These wax eyes are available at the cost of hardly 100 rupees from the Madhu Surgicals, and the goat eye training we all know. But the placement of these equipments and other thing apart from this requires something different. And one thing which is important in the requirement is have a, if not refrigerator is available, then have a thermocol ice box, because these goat's eye die faster than the another other things. So after, if you hold it, bring it at afternoon or morning, so by the time of evening it will be of no use. So if you kept it in a thermocol ice box, or if refrigerator doesn't have, it works good. Somewhere like in IC, in RPC and other centers, they have a microwave. So if you can wait at 100 to 200 degree and microwave these goat eye for 10 seconds to 20 seconds, it will become slightly harder for the phaco trainees. And there will be some whiteboard or something which whoever is the trainer who can guide it, give them the arrangements for that. And one thing important is that whatever the arrangements I have saw, means many places seen the wet lab, and they simply kept a stool. Whatever we need is just to adjust the height of that. So at least we could provide a patient stool, means which height can be adjusted, so that these trainers and trainee can go easily and see with the microscope. These eyeball fixating devices are available at many companies, and many are available. And if you can see, we have this type of plastic manicures, or these are a wet lab eyeball fixator. This is you use a very small space, means just a small table. You just put your goat eye on here and hold it and do the practice. This is again we are doing it in SSTC and different places. If you attached even the vitrectomy, anterior vitrectomy, you can easily do it with the goat eye. This is the applicator which we have created, especially designed with Madhu instruments for the applanation tonometry. Here you have seen that this is attached with your slit lamp. So just you fix your goat eyes here and do the practice of the gonio or the applanation here. And in GSI we are using it. And this is a very good, means whatever if you are using, means most of the time previous fixators are only the table based, but this is the only fixator which is available on the slit lamp mounted, where you can mount on slit lamp and practice another thing. Yes, the wet lab curriculum is important. Here you have seen we have make a wet lab curriculum published in the ISO, means what is the expected from the first year, second year and the third year training. First year is basically whatever we already did in our residency, means hand-eye coordination, doing suture practices and other thing on the cadaveric eye and other thing, and the placement of whatever the rigid and other IOLs. And second year we move more for. If we have a cadaveric facility available or another thing possible, give whatever the 5-7 steps are there one by one, and final years if it is for FECO and other thing, you can go for the training and what is with machine and extra. Simulators are again a good options, but it is the costly, means if anyone can afford the simulator, it's good. There are 2 companies at present available in India, means they are providing a simulator. One is the VR Magic, it is a German made company, and other is Help Me See, it is available in the Mumbai too. So cost, I tell you that it doesn't cost too much. Once an institution has decided provide a room, any of your old microscope can be used, and all these cost you even cut down with the help of the RO labs or the unsterilized suturing or the surgical things available at your place. If not there, then simply buy. Most of the time I said residents that you just go and buy one head that is available for the plus 10 diopter plastic forehead box of 300 or 400, and start and take that one eyeball holder. It cost for the 3,000 to 5,000. So within 6,000 or 7,000 you can set up your own wet lab at your own hostel. It is almost less than a pizza party for them, and easily they can set up their own training and go for that. So just placing a plus 10D lenses they can also do. Few things we have already published in the IGO. It was the article in the COVID times, means how to set up a wet lab. If anyone interested, we can give. With these words, the take home is first plan, means what is your space is available, from where you can get this costly, means microscope and FECO. These are the 2 costly instruments needed. And third one is the fund. Fund usually most of the institution or the training institution can arrange. This is not then. But the knowledge is the most important, means how we can set up, from where we can buy these wax size, from how we can get these unsterilized sutures. These things are the important. So anyone, if we plan like that, then I think it will be a best thing to plan. Thank you, ma'am. Thank you, everyone.
Thank you, Dr. Deepak, for the great presentation. Any questions for Dr. Deepak? Dr. Deepak, how do you monitor the utilization of the wet lab by the students?
Ma'am, there are as far the curriculum is there, and second thing is what we have said that at least we have one attachment, means the trainer or the senior resident or anyone who can watch them. And the most important for any of the ophthalmological surgery is the instrument holding and how they adopt from the microscope and IPD. If these 2 things anyone can adopt, then wet lab will be the good thing for there. And second, if some places on the TV or the recording system is available, they can even take their own recording. It is normal for the human eyes, but if possible, then an institution can also provide them some recording cameras from where they can take it and take the guide from the mentors.
Thank you.
Ma'am.
Can I add a few points?
Yes.
I think you mentioned that there should always be somebody attached. So it's important that the faculty knows that they have a roster or something like that, wherein they have to give their time instead of. That really helps to ensure compliance.
It's the dependence. Look, for the 1 setting or 2 setting, every place faculty is guiding. No, I never find any faculty who is afraid of teaching.
Yeah.
They are ready to guide, but only thing is that for the initial sessions, 3-4 sessions, they can guide. Then any senior resident or for the JR1, JR3 is again a faculty, and he can monitor whether he is making good side port or not. And what ma'am say, if we have a recording system or documentation system, then they can watch it, or at the whenever the faculty is free, they can take over.
And regarding the use of the non-dominant hand, I felt that if they're encouraged to make a second side port, even in the wet lab, that might help them. Because when all of a sudden you transition them from SICS to FECO emulsification, I've seen one of the residents try to use their right hand to make the left side port.
Look,
so I believe the problem still exists.
For my experience is that if they practice 360-degree suturing like we are doing in PK, then their both hands will be free.
Yeah.
Suturing is the only thing which makes you learn as fast as possible. Instead of side port, you are making one or oblique or the thing. But once anyone can practice a 360-degree suturing, just like one microtome cut and just suture that go tie, it will give you full freedom in the both hands. That is my experience for the teaching.
So another point for that is if we could use the artificial anterior chamber that is used in lamellar surgeries for cornea for fixing the eye, it's much more stable than
Yes,
the goat
it will be used for
So
the
that
wet
has
labs,
been-
wet labs in DSEC or DMEC or the
Yeah.
laminar procedures.
Yeah.
But for the PK, this goat's eye, which will be either hardened or only thing, if you inject 0.5 ml of formaldehyde inside the goat eye, it again hardens it. It
Exactly.
will works for you for that means it will be hard and you can hold and cut it.
Okay. Thank you, sir.
Thank you, Dr. Deepak. Please
Thank you,
collect your
ma'am.
certificate.
Thank you.
So now we have none other than Dr. Meenakshi, who is most apt for this session. So over to you, Dr. Meenakshi. Meenakshi was the academic in charge of Shankar. It's written here? Yeah. Of number 1.
उस तरफ है क्या?
Please reset the timer.
You know, actually, while you're finding my talk, if I thought, do you have to be somewhere else, Haripriya? Are you okay here? So I thought it'll be a nice, Dr. Akshay, don't go anywhere. Okay, no, I just thought if we talked about the wet lab, and if your slides are up there, if we could just move on to simulation. I thought it would be a nice continuation. Yeah, if you're ready, while they're looking for my slides. I have no idea why. Anyway, we'll figure that out. So, are you ready to go? Yeah, great, Akshay, come.
Thank you to the ARC and Dr. Meenakshi for curating this program. I think it was a good segue to come from a wet lab, a talk on how to set up a wet lab, to simulation-based surgical training in India and how the past decade, more specifically the past 3-4 years, have changed the training landscape in India. I am a consultant for HMS Vision, which is the subsidiary of Help Me See, one of the companies that is manufacturing a simulator, so that is a disclosure that I'd like to talk. Before I dive into how simulation is gaining traction in India, I thought I'd go over the types of simulation available in ophthalmic practice and the different types of simulators, and then go into the India story. I know when I'm talking to a group of ophthalmic trainers, I'm preaching to the choir, but when we talk about simulators, we think of high fidelity virtual reality simulators. But even a wet lab where we use a goat's eye is, of course, a kind of a simulator. And simulator can not just be surgical skills, it can also be clinical skills. You have the indirect ophthalmoscopy simulators. You have reti, simuli, which are not just visualization and skill simulators, but also things like lasers can be learned on them. You have simulators classified based on the device that they are being used. They could be animal models, human cadaver eyes, inanimate objects, mundane day-to-day routine objects like an aluminum foil, a peel of a tomato, and of course then you have the pinnacle of simulation-based training, which is virtual reality-based simulators. We often hear the words wet lab, dry lab. Wet because we're using chemicals and tissue that can be wet hazards. Dr. Deepak mentioned how a microwave is used. This was a paper in Journal of Cataract Refractive Surgery, where they microwaved the goat's eye for about 30 seconds to induce heat coagulation of the lens to induce a cataract. So, of course, biological tissues have always been used, and you can combine them with multiple things. Artificial or inanimate wet lab training is also possible. You have the Kitaro eye kit, which is very, very lifelike in certain conditions, like say, for example, making a paracentesis and trying to, the video is running, yeah, I think. As always, the video runs well in our computers, but all right. So we've also got some new developments, such as the Vitret-Eye, which is by the Philips Studio, not just for cataract, but also for vitrectomy, where you're allowed to, where you can use the vitrectomy probes to eat out all the jelly within. These can be reusable as well. And something as silly, like I said, not silly, well, I think useful, because the moment the aluminum foil is under tension, it mimics the capsular tension that you would get in a cataract, in a patient with cataract. So it helps to develop the hand-eye skill coordination. These are tasks, these are more of task trainers rather than surgical trainers. They help you develop a particular task or a particular movement. But at the end of the day, we train people in doing these things in goat's eyes, on Kitaro eyes, on tomatoes, on aluminum foils. How do we know it works? Can we assess the performance on a simulator or a simulated model? And that's where virtual reality simulators come in, because unlike all of these other models that we spoke about, there is no worry of collateral damage. You can have multiple attempts. Now, even in a goat's eye, you've emulsified the nucleus once, the eye is virtually useless. However, on a virtual reality simulator, you can do it multiple times. You can learn, unlearn any wrong technique that you have, relearn them. It's a pressure-free environment, because you can have a lens drop without worrying about what happens to the patient the next day. To assess the skills, you can assess it in two ways. You have a cognitive skill assessment and a technical skill assessment. Now, we know the ICO Oscar, it's a very good rubric to assess the trainee's performance. You also have an ICO Oscar for M6, or manual small incision cataract surgery. Now, this has also been extrapolated to a SIM Oscar, where you can assess the performance of a trainee on the basis of their performance in a simulator. Now, why this has been adapted more specifically to the IC simulator, this is also applicable to the Help Me See and other virtual reality simulators by replacing certain items from the original Oscar into the SIM Oscar. And Will Dean has published this paper where they assessed the performance of trainees who learned on the simulator and assessed their improvement and charted their competency over number of surgeries based on whether they learned on the simulator, and compared the simulation group versus the control group. And you can see that the blue graph goes up immediately, which means they've reached a certain level of competency far before the controls who did not learn on the simulator. Virtual reality simulators allow their inbuilt AI to assess the scoring and performance on their own. The moment you reach a particular level, only if you reach 100 are you allowed to go to the next level, which gets unlocked, or the next task. Similarly, on the Help Me See simulator here, for example, okay, the video is running here, but not there, is it? Yeah, it's running on the screen there, yeah. So here the trainee is trying to prolapse the nucleus into the anterior chamber and is inducing a lot of zonular damage. So all of them pop up, and if you see on the screen the performance assessment, you will see that it shows up as an unsatisfactory attempt, because that's how the simulator is inbuilt. It's able to assess each performance and give you a gradation and tell you that you're not doing this well and you need to do it better. So now you've assessed their performance on a simulator. How do we know that does it translate to real life skill in the operating room? And vice versa. If you have a good surgeon who's already been performing surgeries for many years in the OR, if he were to sit on a simulator, wouldn't he do very well on the simulator from the get-go? And that's what we've seen. Now, there is enough literature to show that there is good construct validity. Performance on the simulator improves performance in the operating room, reduces complications amongst residents. So this transfer of skill is essentially what in the simulation world is called construct validity. And when we look at India now, about 5 years ago, we had this survey, which Dr. Deepak and I were a part of, where we asked residents, and this was 740 residents across India. Less than 8% had access to simulation-based skill training. So that's a very low number that we have. Since then, of course, there has been a a paradigm change in this. We have multiple institutes that have adopted simulation-based training. The IC model, the IC simulator, the Help Me See simulator, and this has resulted in a lot of improvement, and I'll share the numbers. This was a paper that we published which actually compared the effectiveness of simulation-based training. Shankar Netralaya, Mahatma Eye Institute, and LV Prasad had their residents, which were randomized into two groups. One underwent simulation-based training, the other continued wet lab training like they would. The first 20 live surgeries of each of the trainees in each of the two groups were recorded and assessed by masked observers. And what they saw was in the control group, which is the non-simulation group, each of the individual errors which were predetermined, uveal prolapse, buttonhole, this is for SICS, premature entry, DMDs, laceration of the tunnels, iris touch, lens touch, all of them were significantly lesser in this simulation group. In terms of minor errors, major errors, the technique score, the outcomes, and the eventual visual outcome in the group that underwent simulation-based training was much better than those in the non-simulation group. Since then, training has happened at Mumbai, at Arvind in Madurai, LV Prasad at Hyderabad, Shankara in Bangalore, and two other institutes, Amala in Kerala and Shankara Netra Chikitsala in Eluru. Last year, a total of 435 residents out of a pool of 6,000 residents in training in India underwent simulation-based training. It's not been an easy way, and it's not to say that this is now fairly available and accessible. Cost remains a barrier. Also a mindset in terms of trainers, the willingness to let trainees train, to take a week off, go to a training center, undergo simulation-based training, is certainly there. However, subsidized training models like the ones that we've developed with the All India Ophthalmic Society, AIOS Prayogshala, have been a boon. Now, what AIOS has done is they've allowed the Help Me See simulator to be housed within the AIOS office. It's an instructed guided model, which means there's a 4-day SICS or a 4-day FACO course. The AIOS houses the simulators at no cost. They house the instructors at no cost. They house the trainees at no cost. And they just facilitate the trainers, the instructors, and the trainees come into the AIOS office, learn simulation-based training. In the past 5 months, we've trained 54 trainees on 71 individual unique courses. And I think this partnership, at the end of the day, organizations like Help Me See are at the core of it non-for-profit, which means they're looking only at financial sustenance, because simulators will evolve and help trainees get better at surgery. And these organizational supports will help create long-lasting partnerships. At the end of the day, the only thing that we are looking is reducing collateral damage and improving the outcomes of patients in whatever we do. And I think these adoption of simulation-based training is definitely a step forward in improving outcomes of both the trainers and the trainees and the patients. Thank you.
Thank you, Akshay, for that wonderful talk. And I also agree that for the residents and the fellows training, simulation on every type of ophthalmology-related surgery should be done in every institute. So it's really nice hearing to you. And to maintain the continuum, we can have Dr. Helena, please, as the next speaker.
Yeah,
and then we can have a
minute.
discussion, because all the three topics are interrelated.
Dr. Akshay, do you foresee that in the future everything will be simulation?
Probably not, because I think even to develop a model like SICS or FACO for each of the different virtual reality-based simulators has been quite a labor and resource-intensive thing. So for finer surgeries like, say, iris hooks or like putting in an ACIL or ICLs or LASIK, these things probably will take a lot of time. But eventually, I think it will get more accessible. I think both IC and Help Me See, now they have the Orbis simulators. They're getting more smaller, more compact, more accessible and portable. So eventually, yes.
Dr. Akshay, can I ask where you would put it in terms of how you would integrate it with wet labs prior to them actually starting operating on eyes?
So if you were to, in an ideal world, a simulator is supposed to replace a wet lab. Simply because, in a wet lab, you can use, say, a goat's eye or a human eye only once per trainee at one attempt, whereas a simulator allows you multiple attempts. So in that sense, you would be, it looks to replace it. Simulators, but you know, again, certain tasks you need to get the real feel of the tissue. So in terms of where would I place them, I'd say they are complementary to each other at this stage.
Yeah, Akshay, please come and collect a certificate. Dr. Helena, are you ready?
I have some slides, please. Can
Yeah,
I have my
I
slides?
think it's coming there.
So,
Dr. Prabhu, just check whether Madam's slides are there.
thank you. Thank you so much. We still don't have them?
Yeah, they have it. I'm sure they have it. Yeah, it's coming.
Yes, they are here already, but not in the... Okay. Thank you so much. Again,
The mic.
the QR code of the Ophthalmology Foundation. And what I took from this title, this topic that I was invited to invite all of us to explore, was, I think, will be encapsulated in the sentence, swinging the feedback pendulum from recipes to relationships regarding good, constructive, effective feedback. So this is not my sentence. It's the sentence of someone I admire a lot and has developed very important work within feedback, Subbaramani. So the goal is to be better able to create a culture of feedback. I would like us to think about an environment that is prone to seek for feedback, and that feedback should be embraced by those who receive feedback to be effectively taken, and hence the word of culture. And also thinking about the global perspective, which is contained also in the title, the global perspective of seeking and giving feedback, and the differences that the diversity of looking at this topic can also assume in terms of giving and receiving good feedback. So the objectives: explain the concept and principles very shortly, describe some models, more to focus that there are models, not so much to focus on the models themselves, and then enumerate key elements of a culture of feedback. Feedback is a regulatory mechanism where the effect of an action is fed back to modify and improve future action. And this seems somehow a made sentence, but it has all there is to apply in practice for constructive feedback. So the aim is to modify and improve future action. And this is the key of the word of feedback, in the concept of feedback. Whereas feedback in the assessment cycle, it's for sure for learning, happening during the learning, and is about assessment that is formative, something that is provided at the clinic, daily practice, and is given and happens to improve as best as we can the learner's performance at the workplace. Feedback should be then a skillful interaction between the provider and the recipient, should be focused or based on multiple sources, should be timely and frequent. It means that it should be given frequently and exactly at the moment where it should be and could be more likely to change an action in terms of being better at what is being done, should be tailored, should be focused on the learner, and should be embraced by the learner. And this is something that we might be in doubt when we provide feedback, is how the learner is taken the feedback that is given and how it will be translated into practice. And this is the key, the pivot for the change of the action of the learner to be better, constructive, and focused on the future. This means that when we give feedback, we should not only celebrate achievements, look for areas of improvement, but also design proactively with the learner a plan for the future. The idea is to modify, to be better in the future, and help the learner on that. Reciprocal, meaning that this is a bi-directional relationship between the learner or the recipient of the feedback and the provider, the educator. So both of them should be related in a synergistic relationship. Feedback is not evaluation, is not the summative part of the assessment cycle as we have seen. Should be formative instead of summative, immediate, informal, based on current performance, so be timely and frequently, as we said before, and not about past performance. Should foster learning, and it's not about giving a certification, it's a dialogue. It means that the provider has also the feedback from and the ideas from the recipient of feedback, and also be specific on an action, a task, something that has happened very shortly when it's given. How can we give good feedback? And we know there are a lot of models, and that there are a lot of recipes that we can use. Probably what I would think, at least to myself, and share with you, and would like to know your ideas about that, is that it's a stepwise. So we have always these main thoughts in our head. It's about celebrating the achievements, celebrating successes with our learner, and then exploring those areas, those specific actions that weren't so good and could be better, and build upon those successes, and also build upon those, so to speak, failures, and move it forward within a plan that is designed, is created by both of them to apply in the future, always with the aim of a growth in the future. So there are several models, several based on 3 steps, others on 4 steps, but what I would like to emphasize is the relationship that is involved. This is a very known model, so it's about praising successes, and then also, and very importantly, in the middle, kind of the meat of the sandwich, is learning about what the learner felt about what he or she has done, and what could be better, what were the difficulties found during that task or that experience. And then design some plan for the future. And this is another one, to build the relationship, explore what the learner has to say, then what would be the best way to approach in the future and change, coach for change. Again, this is a 4-step model, and this is also another model that is very easy as well to keep in mind, but I would like to emphasize what the author of this model said. We must see people in terms of their future potential, not their past performance. Past is about the summative assessment, and not the formative assessment that is feedback. So it's about the future, it's about the future performance. And then just to close, there are other models, close these models of giving feedback. This one, for instance, about knowing how our learner interprets, has the representations of reality, and these will for sure gauge the actions that lead to results, and then debrief about these results, how they are connected with the actions that we have seen. And inclusive as this, also changing a little bit will happen if the learner embraces the feedback, change how the learner sees these the reality in the future. And this is something that we could use. I think, I am curious about what why did you did this or did that? How can we create a culture of feedback and improvement? Models have been mainly focused on praising teachers and learners at the center, but let's have this perspective of having the teacher and the learner, or the feedback provider and the feedback recipient, and focus a little bit in making this into part of the equation, the relationship between them, and also the context where this feedback happens. And so this was some kind of proposal in terms of the feedback provider, for instance, to promote this culture of feedback, be a role model, observe the learner's performance, facilitate reflection, for the recipient, for the learner, to foster a growth mindset and encourage feedback seeking and plans with the teacher or the educator, the future plan ahead. But we know that this can happen at the most if we can found a good relationship, a trustful relationship between both of them, to build this educational alliance, as you can see here, and also co-create learning opportunities for the learner, especially find areas of improvement, take awareness of their most and strong abilities and areas, and also change behavior on those that are not so strong yet. And also the institutional context is very, the so-called hidden culture of the organization is very important. How the institution also nurtures this as learner self-efficacy, ongoing practice improvement environment, and feedback culture for professional growth. Trust and dialogue could be the keywords for these relationships of feedback to be more constructive and effective and enjoyable for both of the educators and the learners. And also, instead of looking at failures as shame, waste, or loss, looking at them as new opportunities for learning. In summary, feedback should be given in a protective environment, timely, frequently constructive, celebrating achievements always, and always not leaving the learner in the nowhere land, but planning for improvement with the learner agreement. Effective feedback is embraced to advance professional growth, otherwise it will just be a recipe, and a recipe with no cake in the end. And a culture of feedback is based on constructive and trustful relationships, and also the context where it is provided. Thank you.
Thank you, Professor Helena. So, any addition or any question to Professor Helena?
We are going to have another talk on feedback shortly.
Okay. Please come and collect your certificate. So, Dr. Meenakshi, are you ready now? Yeah.
Yeah, now it's coming on. Good afternoon. Once more. I had such utmost faith in the All India Ophthalmology Society's online speaker-ready room. And so I did not even check if my talk was on. And but I first want to thank Prashant Bavankule, ARC chairman, who is not here, who is on his way, for giving me the opportunity to curate a program like this one. And for all the speakers to enthusiastically, some of course after a lot of harassment for participating. But particularly I thank Carl for initiating me into this whole faculty development, education way back in the good old ICO days. So this is actually about, this segment is about evaluating how good your trainee is. So we have clinical evaluation, we have evaluation of surgical skills, and then we also have evaluation of how good your training program is doing. And then after all that, then you give feedback. And you heard from Dr. Helena about feedback, and you're going to also hear from Carl about feedback. So my role here is to talk to you about how to do clinical skills evaluation in a really busy clinic. We're all busy. We have to finish patients on time, then we have to run for classes, and then of course we have to at some point go home. And so how do you do this in a busy clinic? So the objectives of my talk are introduction, recap of the OCEX, the Ophthalmic Clinical Evaluation Exercise, and experience with barriers, solution to OCEX implementation in a busy clinic. What are these other things, the other tools, Mini CEX, DOPS, and IDOCS? So the OCEX, as I understand, was Dr. Carl's thesis way back, which was published in 2004. And the second 2.0 was published in IGO in 2021. So what exactly is the ophthalmic clinical evaluation exercise? It is an observed encounter between a resident and a new patient. The evaluator should be present in the exam room for the entire interaction. The intent is to rate the resident in all the categories listed below and then provide immediate performance feedback. I know some of you are already thinking, right, observed encounter in a busy clinic, but let's see how to go about it. So first, let's get familiar with the OCEX, okay? So it is a rubrics-based system which makes the assessment objective. So if you look at the components, look at the first is the interview skills, which include introduction, chief complaint, history of present illness. Some of this is unique to other countries, like pain inquiry, we don't ask. All the patients will have pain. And then allergies or adverse reactions to medications, review of systems, and then past systemic history, past ocular history, social history, habits, and family history. And then you, of course, have examination skills, which include, you start off with hand hygiene. And then there is visual acuity, pupils, visual fields, motility, external exam, slit lamp, intraocular pressure, fundoscopy. And if you look to the right, you have a rubric which helps you score them. So that at that day, in that mood, whether you're in a good mood, whether your resident is irritating you and you're not scoring them, poorly or fairly. There's a novice, a beginner, and competent. And there is a description for each one of these. So you just look at that, look at the performance, and then score. Most important, often neglected, are the interpersonal and communication skills, which look at patient comfort, empathy, respectfulness, explanation of findings, explain the diagnosis, explain options and the plan, and ask the patient if they had any questions. All this your resident is doing while you are observing. Okay? And finally, they summarize this whole thing and present it to you as a case presentation. This is very important for exam, for their final exam. Okay? So, and then you give the feedback, write down the feedback, make the residents sign that they have read it, they've understood, and you sign and then give it to them, dated. So you're wondering how often, how frequent, how do I have time to do all this? Who is going to do it? So I'm not going to do the scoring part because, I have a video like this playing, and then I give you the sheet and then say, why don't you score it? I've asked them to check the pupil, and this is the pupil check going on. So if you are a trainer, how would you score this? Is it does not check, does part of the pupillary exam correctly, or checks light reaction and RAPD, size, symmetry, and uses correct technique? What do you think? You think this person is a novice, beginner, or competent? Beginner. So something like this. So you would use this to train your faculty. Examples like this. And here's one more, it looks at ocular motility. So I said test the ocular motility, and this is what the resident does. And then I said, it's over? He said, yeah, it's over. But where is the cover test? Okay? It does look more like a dancing eyes sort of thing. So is this person a novice, beginner, or competent? Somewhere between novice and beginner. Checks movements incompletely or with incorrect technique in some aspect. Correct? So that's how you will use. And why do you use a rubric? Why do we need this? Because teaching is not equal to learning. So really, who needs an evaluation of their clinical skills with an OCEX? Ophthalmology residents, medical students during the ophthalmology rotation, subspecialty fellows at the start of their training. You want to know how much ophthalmology they know before they start their subspecialty. Allied specialty residents in Shankar Nethralaya, we used to have, sorry, that's different. We used to have people from neurology or medicine who come and observe you, who have come for a month of ophthalmology. You want to know, make sure they understood basic ophthalmology techniques. Optometry trainings, ophthalmic nurse technician trainees, all of them, the OCX can be applicable. So when do you want to do this during the training? So the OCX comes under a category called the workplace-based assessment. Okay, it's done in real life in their workplace. So it can be used as a formative assessment, which means you can use it at the end of the first year to see what they've learned. You can also use it as a summative assessment to see, hey, is my trainee ready to go for the exam? Okay, where maybe it's trainee ready to go for an FRCS exam, where everything, the exact technique is supervised, is looked at and graded. So you can use it either formative or summative. So how did I do it in Shankar Nethralaya? So I would do it on my off day, my academic off day, and this was already scheduled. Which resident will have their OCEX? So the secretary informs the resident and informs the faculty with who the resident is posted, saying, this resident is going to be gone for about 90 minutes. And then the resident shows up, and then I'm just sitting quietly, and then I tell the patient, so the resident is in the white coat, and I tell the patient that this is a quality check. So residents and the patients often don't mind. You say, tell them, I thank you for your time. It's going to be, and ours is a private hospital. So you can't just drag some patient and make them sit and ask the patient will think they're experimenting on them. You're learning on me. I am guinea pig. No, you tell them this is a quality check. This doctor is the future doctor. From next year, he's on his own practicing. He's going to be operating on you later. So this is a quality check. They are usually understand. I've never had a patient who have said no. So explain this to the patient, and then the resident starts, and then I just sit in a corner and observe the whole encounter. And including refraction, including retinoscopy, all of it. I always, in Shankar Nethralaya, had the refraction rechecked. But you have to watch the whole thing and then have them present it to you, okay? So anyway, so this is how it happens. Sometimes, occasionally, we will also have them record and present it to me, the encounter. So the potential barriers to OCS implementation are the assessor's time, assessor's training, other faculty cooperation, from whom the posting they're relieved and they come to you for 90 minutes, they have to buy in. And then the trainee availability and feedback and follow-up. So the OCX is a great multi-purpose tool. It's a great tool for assessment, good tool to teach with. Professionalism and communication can also be assessed, and you can know whether your trainee's exam preparedness. There are also mini CX available, a short episode of real student-patient interaction with the workplace. There are mini CX which only looks at each one of these. And then this has been studied. The reliability has been studied. There I found a very good one, mini CX, for just strabismus evaluation. You can also make your own mini CX. Just make sure that that inter-rater reliability has been established. Okay? And there is something called DOPS, which is also part of the workplace-based assessment. This is observation, evaluation of a procedural skill, okay, by a trainee on a real patient. And again, you do the assessment, evaluation of a specific patient encounter. Did they do informed consent? Did they explain to the patient what they were going to do, etc., etc. And then you give them feedback. That is key. This is an example for DOPS, I think is adopted from the Royal College. RC off the DOPS example. And then you have the MSF, which is, again, a multi-source feedback, a complete topic in itself, which is called the 360-degree evaluation, where you get evaluation you get feedback from not just the faculty, but the patients, the peers, students, nurses, staff, because they may be showing good attitude to you, but they may be, harassing others. So you could also have case-based discussions, also part of clinical evaluation, assessment. And there are many, many types of case-based discussions. And then we finally have something called the IDOCS, which is International Direct Observation of Clinical Skills for Subjective Refraction. This is again broken down into steps. In conclusion, there are many tools available for clinical evaluation of skills in the clinic. We looked at the OCX in great detail. They belong to the broad umbrella term of WPBAs, workplace-based assessments. The OCX has an application in a wide variety of settings to evaluate many categories of healthcare professionals. If you just, with a little bit of imagination, you can incorporate it into your program. It will give you immense feedback about your trainee, where you need to be focused. It will give immense feedback to the trainee, where they are and where they need to focus. Thank you so much.
Thank you, Dr. Meenakshi. For the interest of time, may I call upon the next speaker, Dr. Haripriya, and Dr. Meenakshi, please collect your certificate. Dr. Kaz.
One is about the student knows that he's being watched, she's being watched. Does it add a confounding factor? Yes. Number one. Number two is that a lot of things can be done on a healthy volunteer. So is it that can we replace the patient with a volunteer for the patient's rights? Number three is, do you really also see whether the patient, the student after examining, you're only looking at what she or he does. What they actually interpret, is it also taken into consideration? They check the pupil, but what they make out of that examination is also taken into consideration.
Good question. So the OCX is designed, I believe, to look at whether the clinical evaluation steps are followed in its entirety. Okay, that's the first consideration. Because if you do not do the steps correctly, if you do not do for example, you're going to do strabismus evaluation and you do not do cover tests for distance, near, and ocular motility, then it's very highly likely that you may miss findings. So this is the first step, right? The accuracy of the find. So this is the first basic thing that needs to be established. Accuracy of the findings. Sometimes can be a guesswork also, you're finding, or maybe somebody mumbled outside saying this is what this patient is, interesting patient of advanced POAG, and you already are imagining the disc, right? So that is the second step. I think both are important, but you cannot go straight to accurate diagnosis unless your steps are correct. So that's where it comes from. As the question for the volunteer, you can use volunteers, but if you also want to do both, for example, when I would examine the patient as well to confirm the accuracy of their findings, correct? With the volunteer, there's going to be no findings. But what you can check with the volunteer is the interpersonal communication skills. For that, a volunteer-based evaluation is invaluable. So, but for actual, because we don't have luxury of doing this and then followed by that. You have to do it all at once. So you have to do evaluation of how accurate their clinical steps are and their clinical findings. Hence, a patient is scores better than a volunteer. The whole point is this: if they are making mistakes while you are being watched, what all will they make mistakes if they are not being watched? Carl, you want to comment about that?
Yeah, it's called the Hawthorne effect. Of course, they're going to do their best. You're watching them, right? The professor's there, but all you're trying to do is show they can do it. When they graduate, you're not going to be there, but you need to know that they can do the parts of the exam and they can talk to the patient. So you can't guarantee they're going to do that the rest of their careers, but you'd have to know that they can do it while you're watching. That's my argument against. Of course, they're going to do their best, but you still will see stuff that you can't believe if you watch.
You know, I've actually been on the other side because ma'am administered the OCX on me when I was a resident, and the lessons that I got from that experience have stayed with me till date. So I think it's very, very important for the resident that we do it. I always imagine that I'm in the apron and MS ma'am is standing somewhere nearby. I don't know whether she remembers or not. Anyways, you know, I think we'll move ahead with the next talk in the interest of time. And we'd like to welcome Dr. Haripriya Arvind, Distinguished Senior Consultant and Head of IOL Services at Arvind Madurai, whose videos have always enthralled us, and we'd like to hear from you, ma'am. Now in Chennai. Now in Chennai. Sorry.
I'd like to thank Dr. Meenakshi and Dr. Prajna for this opportunity. So I'll be touching on assessment of the surgical skills more, moving on from the clinical aspects. On the Oscar practice, and also to see is my trainee surgically competent to step into the outside regular practice. So as we all agree, it's critical to have a well-structured training curriculum in place. And the components, as we know, would include having the lectures, make them observe the surgeries, wet lab practice, the actual hands-on on the patients, and the post-op evaluation as well. And we would do this for both our internal trainees, which are residents and fellows, and our junior consultants, and the external trainees as well. So internally, we have trained approximately about 1,200 residents so far since inception at Aravind, across all our hospitals, and about 1,070 fellows in the anti-segment fellowship programs. And we also have a 1-month-long training program, which Dr. Nachia began in 1993, which is still on. The SICS and FACO is still on. And over these last 32 years, this is happening in all our 6 tertiary centers. Around 3,000 courses have been run, and numerous ophthalmologists from within India and across the globe have benefited from this training program. And we try to replicate, you know, the 1 month, whatever training we give for these external trainees, we do it for our PGs and fellows as well. So we kind of make it a very intense training program the first month when we start the program. When we first had to begin the FACO training course in 2005, we came up with a matrix as to what will be the different components of a training program, looking from the different aspects like pre-surgical training, the surgical training, and the post-surgical aspects. And from the perspective of knowledge, skill, and attitude, of course, attitude, as we know, is very critical. Example, during surgery, if the trainee feels that they are not sure about how things are going, they have to ask for help. So all of this is told to them right in the beginning. And we also have another 4th aspect of evaluation, which is also very well incorporated into the training program. Example, following the surgery, immediately they will have to fill their logbooks, do a surgical review of their videos, see the patients on the post-op with their trainers, and look at different aspects like the rexus and if any residual cortex and IOL placement, etc. So through the course of the next few slides, I'll just be running through what are the different things we do at Aravind in terms of assessing the trainees. So the trainer's role is critical. We normally have a single trainer who stays with them through this entire 1-month program. Before they start their actual surgeries, we have heard from the previous speakers that it's important for them to get as much hands-on as possible in the wet lab. So we do the suturing. So we don't do ECC at Aravind anymore. So they do at least 25 sutures every day in the first 15 days. Again, for the different reasons mentioned earlier, this is very critical. And the different aspects like phaco machine connections, foot pedal, all of this as well, we'll have the assessor by them just to see if they're able to get a hold of all these basic concepts before they touch the patient. And the simulators, again, we saw some beautiful talks, and the different hospitals, either we have the Help Me See or the Fidelis for FACO or the Fundamental VR from Orbis for SICS in the different centers. I think it's useful if you can have one of these. The newer ones are more portable, they are comparatively less expensive. And the good thing is we also have assessment score from these simulators which help the trainee and the trainer know regarding their progress. The actual surgical training, for example, if you're going to start our residents on a surgical training, it's the 4th or the 5th month. And this is the number of surgeries they will have to do in the first month. So we really would like to catch them young. We'd like to put a lot of energy in the initial phase itself. And the trainer will be there, of course, with step surgeries initially, and then moving them on to the complete procedure. In case there is any complication, of course, the case is taken on by the trainer. And if the duration is too long, again, the trainer would take over in the interest of the patient and the final outcome. Now, the ICO Oscar, just like we heard about the OCX for the clinical training, this rubric by ICO is extremely useful to assess the surgical performance. The Oscar stands for Ophthalmology Surgical Competency Assessment Rubric. And I think Carl is here, and Carl, along with a lot of researchers, came together and designed this rubric. I think this was first published in 2011, and it had for ECC and FACO. And subsequently, various other surgeries, I think almost every ophthalmic procedure now has an Oscar as well. Little after it was published, we began using it, but many of our trainees in Aravind do SICS to begin with. So we again approached Carl, and then we worked on the SICS Oscar as well, and we use it routinely now for all the trainees who undergo surgery, and we find it to be very useful. Just to understand about how this works, in contrast to the OCX, this has 4 different grades, from grade 2 to grade 5, which ranges from novice, beginner, advanced beginner, and competent. Again, there is no expert level because you don't expect a trainee or a resident to be an expert in the initial phase of their training phase. So, and on the left, we have the different steps listed. It's about 19 or 20 steps. And what I like about the Oscar is in different levels. One is that, when the trainee starts the program, they know what their final goal is to be. They know what they will have to do to be competent. For example, if it's capsulorhexis, they'll have to do it central, circular, without cortex disruption. So this becomes an excellent tool for them to understand what they should aim for, and that journey becomes more well-defined. The second, obviously the more important aspect, is it's a very objective tool. As we know, every trainer, every assessor has a different way of grading, but looking at this, the trainee gets the honest feedback as to where they are as of now. And even if you have a different trainer the next case or the next month, you still have an idea as to how your progress is going. And as I mentioned, the last few are the global indices regarding their tissue handling and other aspects. So it's about 19-20 steps, and each step would go up to a score of 5. So you could probably have maximum of a score of 100 for FACO Oscar rubric. And I think what we do is we have a printout of this Oscar rubric in the operating room. And end of the case, we ask the trainer to then grade them for each of the steps. So this is best done real time. You can also do it later. You can have the video recorded and also have someone do it. But I think that most often gets passed. So wherever possible, we would request them to circle it right then. And if there is time right after, discuss with the trainee as to what could have been better. Why was this a 3 and not a 4? And give them some points for improvement as well. And the other thing we would do is we have this sheet where on the top we have the case number, just to know about how their whole training graph looks like. And for each of these cases, each of the steps, the score is then entered, and then we have a final graph. So this curve gives us an idea as to how their learning curve is. So 2 things. In this previous slide, you will see that if they have any issue with a specific step, like say if it's capsulorhexis, flap, and following through, then they probably need a lot more training in one specific step. Second, overall, how competent are they? Are they ready to now be on their own and perform surgery without any supervision? So all of this we will be able to assess with the Oscar. So before the Oscar, we used to use complication rates as the metric, which is still good, but it's a very gross. It's more like, you have a complication, it's like an endpoint. Our whole goal, obviously, is to prevent or reduce it as much as possible. So, like I mentioned, the biggest benefit that it's an objective tool here. Besides the Oscar, we also use the logbook. So we have the traditional logbook where they would mention at every step what they would do and also give a detailed note. So they kind of know at which step was my incision posterior, how did I manage it, I changed my direction of the knife because it was going too deep. So all of this is also mentioned there. And more recently, we are moving on to a more digital format where they basically make a PowerPoint slide set of each of their cases. They did the first 15, 20 cases and talks about, the critical steps and the slit lamp image as well, pre-op and post-op as well. The idea is also to make it seem like the trainee is being a little more proactive. They take initiative, they take responsibility for their training. So they themselves know how they are progressing. The video is also reviewed end of every day along with the trainers because they are in a more relaxed setting. They are able to discuss things which they cannot see under the microscope. The other thing we use the video is for, like even after they finish their intense 1-month training, we have a review of all the complications which happened the previous week done by the trainee surgeons, which includes our residents and fellows and junior consultants. So this week, this is done every Friday, 5 to 6 p.m. and this becomes a very good learning exercise. Again, not to point a finger, but to objectively say what went wrong. And again, you have more people in the room, so they can learn from each other. And that, I think, is a very healthy discussion, which helps them learn and progress further. And in order to do this, we have a kind of a cost-effective recording system in place. We have the Falcon camera and the AVID media, which are, I think, which will fit into most microscopes, and that's the reason why we're able to do it. So almost all our trainees now record their cases, which goes into our central hard drive, and then they retrieve the videos which they want to see, and then this is shared in the Friday meeting. So aspects like any complication such as this. So here you can see the trainee is going a little too deep, and there's a premature entry. And using these videos, you can actually teach them about how to hold the crescent and the direction of how they have to dip the heel, etc. So the other question which comes to our mind is what is an ideal number of surgeries? So for the question of are they ready to perform on their own, or how many surgeries should a resident do to call them competent, or are they ready to practice on their own? So there are different recommendations. The ACMG, as we know, would say 86. So in the US, all the residency programs, the residents will have to do 86 phaco procedures as part of their norm. We don't have a norm such as that in India. Again, this number of 86 was an indicator of experience. It's not considered for competence. So why 86, I don't know. I don't think we know exactly why that number was chosen. And we have various other papers as well, and which talks about what is the complication rate within the first 80 surgeries, about 5%. That probably is the reason why it was chosen as the cutoff. And it's not just the number of cases, it's also how structured the curriculum is. With every case, are they learning the most significant aspects and how this is taught to them? And in this paper by Rogers, he says that with a structured curriculum, you can almost halve the complication rate. So that is the importance of actually hand-holding them and ensuring they are doing the right thing for every patient at every step. So using the Oscar, so Oscar typically in our system, we normally use it for all our residents and fellows for the first 20 cases. So every case we get the Oscar score. But we just did a thesis, one of our residents did a thesis to understand how can we use Oscar to derive at the ideal number of cases which they have to perform. And with that, I think they did about 250 cases up to the second year of residency. And with that, we realized that they need to do about 119 surgeries to get an Oscar score of 80. So a score of 80 is actually quite good. So 75 to 80, I think, is pretty good. And that is the number we would now recommend, that doing 120 SICS is a good number for them to be confident. And this kind of also correlates with our complication rates. So with this paper, we looked at what was the complication rate for every 100 surgeries which the residents were doing. So in the first 100, it was about 4.14%, drops to 2.55 from 100 to 200. And then after 200, it becomes less than 2%. So this 120 case, I think, is a good number for us to consider. Again, considering we have a well-structured curriculum and training program in place. So besides this, we also have our own Arvind Cataract Registry, where all the cataract surgeries operated, we are able to kind of have an online portal to assess the complication rates, visual outcome, and this is something which they will do even later as they're doing more number of surgeries or as they become a consultant as well. So I think in conclusion, the close monitoring and the regular objective feedback will help the trainees to improve significantly and make them both competent and confident surgeons.
Thank you, Dr. Haripriya. Due to interest of time, I think we should go to the next speaker. Dr. Seema Das, are you here? Dr. Seema is the academic head and also heading the Department of Orbit and Oculoplasty Oculo-Oncology at Shaw Charitable Eye Hospital. So over to you, Dr. Seema. And Dr. Haripriya, is certificate, please.
Yeah, I just want to say
Dr.
that we please, the speakers stay back, so we will have a discussion at the end of the session. The discussions are planned at the end of the session. So it's okay if we eat into the lunch, but we will discuss.
Thank you, Dr. Meenakshi, the whole team, and can I have my slice, please?
That side?
Oh, okay.
Just walk across.
Thank you, Dr. Meenakshi, the whole team, and AIOS for this opportunity. And it was really kind of enlightening to listen to all the talks since morning. And I will be talking about program accreditation. So we have been listening about the program methodologies, the tools that we have, the structures and the resources that we have. So at the end of the day, it boils down to how well we are using all of them together, and that's what an accreditation does. It validates whether we are doing the things what we should be doing the things correctly. So why accreditation? Because we know that unlike the ACGME criteria, where there is a minimum number and certain minimum criteria which is set for getting a certification, we don't have a minimum certification criteria in the country as of now. And there are several reports, published data, which tells us that the quality of the residents which pass out from the various institutes of the country can vary widely. Those who are coming from the premier institutes can be very well trained, whereas those which might not be coming from very premier institutes, the quality can be as low as people graduating without doing a single surgery. So that's where the role of accreditation comes into the picture. Now, why accreditation for us? Shroff has been doing training for a long time, for 25 years. We have trained several long-term, short-term trainees from across the world. Residency was something we started relatively recently in 2007 with just 4 seats. And we felt that we have been doing it, but we need to know whether we are doing it the way the world does it, whether we are at par with the global standards, and that's the reason we thought we need to have an accreditation, and that's the reason we applied for the accreditation from the Ophthalmology Foundation. So accreditation benefits not only the educators, the trainees, but also the institute as a whole, and in the process, everybody benefits. The other programs also tend to benefit. The quality of the training program improves. You are at par with the global standards, and at the end of the day, it's the patient care which improves, and that is what the role of any training program. We received our accreditation in June last year, and we had applied for the advanced level accreditation, and we received that, and I believe we are the first institute to receive the advanced level accreditation. So going through the whole process, I'll just take you through the steps of the process and what has been our experience, where we were, and what are the things which we already had, and what were the things which we had to put in place, the processes as well as the resources. And if anybody wants to replicate it, what should be the the steps. So there are 2 levels of accreditation based on certain parameters, the basic and the advanced standards, and there has been guidelines very clearly laid out by the OF for all of these standards. This is a 4-step cycle where we have a self-assessment questionnaire which has to be filled up. It's a pretty extensive questionnaire covering almost all the aspects of any training program. There is an external group review which happens on the self-assessment, followed by an accrediting organization review. And finally, once you receive the accreditation, you have to apply for a renewal every 5 years to maintain the accreditation. So these are some of the major parameters, and within this, each parameter, there are some minor sub-criteria which has been laid down. Broadly, these are the parameters which covers the structure, process, as well as the outcome of any training program. A self-assessment which has to be filled up by the organization, followed by a site visit, which can be virtual or a physical from the accrediting body, is how the process goes. So I'll briefly go through some of these parameters and what we did and what we had and how kind of easy or difficult it was for us. So educational program, the most important part is the curriculum, which has to be standardized with standard contents covering both the theory and the practical aspects. Evidence-based and scientific methods are a very important parameter. Subspecialty training has to be incorporated in the curriculum, and there has to be an administrative structure and an organogram who is going to kind of oversee the whole training program. It's also important to balance training and service, and fortunately we had already ongoing fellowship training program. Initially we were skeptical whether this is going to be a conflict with the residency program, but we realized that this was actually a benefit, because having the curriculums for our subspecialty training, which were at par with the ICO curriculum with little modification to meet our requirements, it actually helped us in putting up the curriculum for the residency program also. And since we have an extensive subspecialty, we are in subspecialty-based hospital with almost 50 subspecialists, specialists across all the subspecialty, doing more than 20,000 subspecialty surgery every year in the Delhi branch. It was pretty easy for us to give almost exposure to all the subspecialty for the residents. Biostats class module was already ongoing for us. We have been doing it for the last 10 years. Every 6 months we have a module which has been taken by some of the internal as well as external faculty. We have weekly journal clubs where all the kind of, the standard evidence-based protocol is followed whenever a trainee is presenting the journal article. So this part was the one which was a little bit challenging, balancing training and service, because as part of the requirement, the residents also need to get some exposure of the outreach and the community programs. And we have our residents who rotate in the various outreach clinics and the satellite centers of the hospital, some of which can be in the very rural areas. But fortunately, again, since we have full-time specialists in all our secondary level hospital also, while they were serving in the community setting, they also had continuity of their training. Resources, we had a lot of talks on the wet lab. I think that is the crutch of any training program. We need to have a very good wet lab, because most of the things can be covered, at least the surgical training part, in the wet lab. Again, we have a well-equipped wet lab with 5 microscopes and tables. We have a simulator also, and we have been doing a lot of surgeries in the wet labs. In fact, I was just looking through the procedures. We almost offer 42 procedures across all the subspecialties on the wet lab, on the various tools using GoatSci, VR simulator. We have the Orbis simulator, the VaxSci, and many other models like the pig head for the oculoplasty surgeries. So it was pretty easy to give those exposure to the residents also. The teaching tools, we have already spoken about it. Other resources like a well-equipped library with access to the journal articles, reading room facility, classroom with digital connectivity, so that even the residents, they're posted in the outreach clinic, they can get connected to the classes, the grand rounds, which happens twice a week via the Zoom. Research and academics has been another very important aspect, and we encourage all our trainees, residents, to participate in the various forums and the conferences. And I was just looking at the last year data. We had our trainees at 42 presentations in the various nationals and international forum with 31 publications and 4 awards. So it's a culture which boils down even to the residents if it is already existing in any organization in other training programs. Another important highlight, which is important and is an important aspect of an advanced level accreditation, is giving exposure to the residents to global ophthalmology. So as part of global ophthalmology curriculum, we have a residency rotation program where every year our residents, one of the residents based on the performance, get to spend a month in the University of Wisconsin, and their residents come to us for 2 weeks every year. So it's an exchange program which gives the resident exposure to what's happening to the rest of the part of the world also. Assessment system, we have again looked at all the tools, the OSCAR, OSEX, the soft skill review, surgical complications, What we have done for us, we know we have all the tools, but what we found initially difficult was the tools like the Oscar, if it's on a hard copy, sometimes it tends to get missed. Either the resident or the faculty did not have enough time, or they were doing it little later on where you don't remember what happened during the time of surgery. So we put up the whole Oscar and made an app. It's on the Android, it's freely downloadable, and all the trainee, whenever they join, they mandatorily have to download the app. They get their own login ID. There is a trainer ID and a trainee login ID. And every surgery, before they start the surgery, they have to enter in the app. And once they choose the trainer, it will automatically show in the trainer dashboard. That way, the trainer who is standing there, there is a tab which is kept in the training OT and can do a real-time scoring of the Oscar. And that has really improved the scoring process. And another important part, if suppose there is another trainer on the subsequent day who might not know how well the trainee is doing, there is a progress report of the last 10 surgeries which the trainer can see, so that if there is any specific comments given, those will also become visible in the app. So this has really helped in sort of keeping a track of the training. We do maintain a logbook. Fortunately, DNV has a very good structured curriculum. We have just adopted that, put it in the form of a booklet, which is given to all residents, which covers the subspecialty posting with very specific things written down, what they have to do clinically, what they have to do surgically, what is going to be the didactic curriculum. Everything is given at the beginning of the posting. We have a monthly logbook review of their cataract as well as their subspecialty logbook, and the trainers, everybody, it's a common class, it's a learning for everyone. So everybody will be sitting there, all the faculty, to know what has been the progress. And when we are filling up the accreditation self form, it was very easy for us because we already had those numbers as part of the logbook of all the trainees. Selection, numbers, counseling, these are all again part of the process because they come through the NEET counseling. The stipend and all are predetermined, so we did not have too much of say in that. And the other important aspect is the learners wellness program. We try to incorporate those aspects also by having other sessions other than the clinics, sessions on mindfulness. We have an inspired series of lectures where we call the faculty from various aspects of the not only ophthalmology but other aspects to talk about their life experiences and service and other aspects, so that this becomes a motivation and for the trainees also. Trainers, I think that is a very, very important aspect. The trainer need to have dedicated time. They need to have ongoing train-the-trainer programs. They also need an evaluation recognition program. And what we have done is we have a dedicated training OR where the faculty that day do not have any other things to do except for doing the training, and that way they can focus much more on just the training rather than bothering about their own list. Train the Trainer program is an ongoing thing which again keeps on happening. We have several modules which are developed internally, which are taken by the internal faculty, but we do have external faculty. Dr. Golnik has come over several times for doing the Train the Trainer programs, and this is something which we keep on doing for our own trainers. So what we added and modified while going through the accreditation process is the program evaluation, which was not very structured earlier, and taking a 360-degree feedback, which was again, I would say, was not available. So we started taking feedback about the rotation and the experience of each trainee in the various areas, in the various departments, and it was an annual feedback process which was implemented, and that feedback report was then formally shared with each area head, each head of the department, so that they get to know how they scored and what is their score in comparison with the other department. So that becomes an objective way of assessing how good or how not so good they are doing and what are the areas which needs probably corrections. The same feedback is taken for each individual faculty also, both for surgical training in the form of a faculty coaching feedback form, and also as an annual feedback from the residents. This feedback is again shared with each individual faculty, and recently based on the feedback which you received, we started, in fact this year itself, last week was our convocation, and this was the first time we started giving the Training Excellence Award to the trainers also as part of their contribution and recognition to the training, because this is something which is extremely important to keep the trainers motivated to do what they are doing. So just to conclude, the key takeaways are that it was a self-improvement process. It was a self-check and a validation that what we are doing is the right thing, and what are the areas where we needed improvement. And we did a lot of improvement post this accreditation. We got a global spotlight because of that. The quality of our learners has improved. The people who are seeking us has improved. And if I see the data, when we had the first DNB resident who joined us, who had a rank of about 17,000 all India, and this year the resident who took up Shroff as residency had a rank of about 1,200. So that speaks a lot about the people who are seeking you. So, and I would say it's very important to have a checklist to ensure that you are ready for accreditation, and the guidelines gives a very comprehensive checklist. We don't have to do much, just go through them. We just have to implement those, put up the processes, and incorporate the resources. Thank you very much for your attention.
Thank you, Dr. Seema, and congratulations for the accreditation. And I think you have highlighted some very important points, especially the digitalization of the wet lab. So this Orbis International and many of the INGOs are coming for the digitalization on wet lab. I think you're the first one to start in India. We are also going to start this way. So this will really help in the residents' learning and the mentors' training.
Absolutely.
So everything, once it is digitalized, we know actually how much is the quality time that has been spent in training and also in learning. So congratulations.
Thank you.
And now we go for the best. And before that, I want you to collect the certificate. And also I request Professor Helena to please come and collect your certificate too. So we always keep the best for the last. So we call upon Dr. Carl, please.
Okay. No, that's not it. Do you have my slides up there? Guys? Well, I was really impressed with all the talks, and I'm going to talk a little bit after lunch about the Ophthalmology Foundation accreditation program that Dr. Seema just discussed, and how one can go about, there it is, how one can go about getting accredited by international standards. But this talk is on giving effective feedback, and Helena already made several points, and in the interest of time, I'm going to try to sort of go through this quickly. My objectives are to describe the need for feedback. We've already heard a lot this morning about the need for feedback. Define formative and summative, which I think has already been done. Define principles of good feedback, and hopefully to convince you to use more feedback in your everyday teaching. So formative feedback, as I mentioned, I like to think of it as behavior modification. So we are trying to enhance good behaviors and improve not so great behaviors. Versus summative, which means have you met the final grade? Have you graduated from your residency? I think another word for formative feedback is teaching. So I'm going to show you a video. This is a video that we shot. This is ad-libbed. There was no script to this. This is Andy Lee, a good friend of mine, and my medical student when I was a resident. You can imagine that, if you know Andy. And so the scenario here is, I am the residency program director. He is a resident, and he is very smart, but he is missing lectures, and he's late. And so I'm giving him feedback. So take a look and tell me what you think. This has audio, guys, in the back.
Audio.
Try again.
Hey, Dr. Lee. How you doing? Good. Listen, I've been hearing some problems that have been occurring.
Problems?
Yeah.
Not with me.
Well, I've heard from at least a couple people that you're not showing up and lazy.
Lazy? I have a lot of things, Dr. Gold. Well, not lazy.
Well, I've heard that you've been late to conferences on some occasions and have even missed a few.
I don't need those conferences. I just study at home.
Yeah, well,
I'm not even 90th percentile on the board.
I know you're doing very well on the board, and you're doing well on the tests, but we've talked about punctuality and professionalism in the past, and I just need it fixed.
I just don't get anything out of those lectures, Dr.
Well, we need it fixed. We need you to
Half
help.
the time the lecture is wrong.
Nevertheless, I need it fixed. So do your best, and I expect it to be fixed. No more tardiness, no more missing lectures.
Well, if you say so, sir.
Right.
Okay, so normally I would ask everyone to tell me what they thought was good or bad about that, but we don't have time. So I'm going to show you the video on improved version after I say a few words about giving good feedback. So formative feedback should be frequent and timely. Helena said that. If your dog pees on the rug, you don't hit your dog a week later and say, bad dog. Right? The dog's wondering, why? What did I do? You want to do it as quickly as you can after the observed behavior, and if possible, firsthand. So when I first became a program director, I'd hear the story from a faculty member. I can't believe the resident did that. And I go call that resident up. I can't believe you did. And then I got their side of the story. So I always get the other side of the story. Make sure if it's not firsthand, get the other side of the story. We'll talk about how. It should be designed to improve performance. But remember that feedback's not just for people who aren't doing well. It's to reinforce good behaviors. Because I definitely have residents say, I don't really know how I'm doing. And they're doing great, but no one's telling them they're doing great. They're just not telling them they're doing anything terrible. So you want to reinforce the good behaviors so they keep doing it and correct the behaviors that need to be corrected. And so Helena mentioned this, the ask, tell, ask sandwich. And so the first ask is, how do you think it went? So get their opinion so you don't have to figure out what they're thinking. What did you do well? How did it go for you? And listen to what they have to say. The delivery of the tell, be objective and specific and constructive. You're trying to either reinforce something they're doing well or make some improvements. So you should focus on behavior, not the person or the personality, like I use the word, you're lazy. What does that mean? Use the SMART system. Specific comments in small bites, measurable outcomes, accountability. If the learner doesn't think he's wrong or he needs to be changed, he's not going to change. And I think with that first video, he didn't think he's smart. He doesn't need to go to the lectures. Is he really going to change? Make the recommendations for change realistic. You can't go from the first percentile on your exam to the 100th percentile in a month, for instance. And timely, I already mentioned. So some examples. Bad. Too general. You're not doing it right. How do I fix that? Versus specific. You can improve your technique by, I can fix that. Judgmental. Your history was terrible. Versus, your history was too long and not focused on the chief complaint. I can fix that. Personal. You're just not reliable. Versus, sometimes you forget to dictate the operative note. Okay. So those things on the right, fixable. On the left, not fixable. So the second ask, what would you do differently? Maybe we should consider this, or we should work on this. Let's monitor the improvement together, and let's meet in a month or whatever the right time frame is to see how we're progressing. So let me show you another version of the video with audio.
Thanks for coming in. I'm curious, and I know we meet once in a while to talk about how things are going, and I'm curious how you feel like you're doing.
I think I'm doing great. I'm like 99% on the course.
And I think there's no question you get the highest scores, really, of our residents on those tests that you've been taking. And I think you're doing very well. So however you're studying is working. Anything else? Any problems? Or?
Well, sometimes I don't think I get as much out of the lectures as I should be, so I stopped going.
Right. Well, we talked about at the very beginning of the year about punctuality and about our expectations. And although you're right, you do very well on the tests, it sets a real bad example. And I think some of the other residents look up to you, and they may not know how well you're doing and how well they're doing, and they may get the wrong idea. So from a professionalism standpoint, I think it's important that we try to fix the problem. And I do have, we do take attendance. We do even sort of have the professors note if your people are late. And I can tell you that you've missed, as you just said, you've missed 5 lectures in the last month, and you've been late to 5 more. And that's, I think our next closest resident's been late to 1 lecture and has missed none. So you're clearly you're an outlier as far as that goes.
Wow, I didn't realize you took attendance or you noticed I wasn't there. I thought you just had to get high score on attendance.
Well, part of being a resident and being in the program is to go to the lectures and set a good example. So I think what we'd like to do is try to have you attend the lectures. And I know you may not think you're getting a lot out of it, but and I know you're doing well, but I think attending the lectures is part of being a resident in this program, and being on time is important. So we're, of course, going to continue to monitor that, and hopefully when we meet again in a month or so, we'll be able to have a bit different conversation. And I really think that if we can fix this issue, you could be one of our very best residents.
I definitely want to be the best resident.
Okay, well, we'll plan on meeting in another month or so. We'll see how things go, and we'll monitor things and take it from there.
I promise you I'll be there.
Okay, thank you.
Okay, so a much different scenario. I think he felt accountable perhaps, but tried to give him some data. You missed 5, the next closest is this, and explain to him what the problem is. So a better example. So feedback should be useful. It should point the learner in the right direction, whether they're doing well or they need improvement. It should improve the performance and motivate them. And remember to give feedback to all your learners. It's easy to tell someone who's not doing well, they're way down here, how to get better. But someone who's up here that you want to make great, that's harder. But you got to figure out how to do that. Failing to give feedback, well, it leads to mixed messages, false interpretation by the learner. They may think they're really good and they're not, or vice versa. And then ultimately lack of trust in you, the teacher. So, in summary, feedback is crucial. Try the ask, tell, ask sandwich. Checklists and rubrics, which you've heard about, can create structure and make the assessment and the feedback more objective. I gave this talk some years ago at Aravind. We have an IXL course every year, and my daughter happened to be visiting, and she just happened to be there for this one short lecture, and she came up to me. She was, I think, 16. She came up to me at the end of the lecture and said, "Dad, you don't give me the feedback sandwich." So I think you're right. So hopefully I've convinced you to use more feedback in your teaching. Thanks for your attention.
So with this, we conclude this session, and thank you, Dr. Meenakshi and Dr. Karl and all the speakers for this wonderful session.
You have to sign away.
And the certificates, please.
Yeah, I think for, because of the time constraint and we have to start on time, the afternoon session, we could step out for lunch and then continue any discussions, questions, queries that are not burning over lunch. Thank you.